So I want to talk about SVT, particularly because we've had a baby recently who's had it with quite a lot of prolonged episodes. So I just thought it was worth us kind of recapping on the anatomy and the main kind of management points of it. So it's one of the most common arrhythmias we see in neonates. Obviously, luckily, most neonates don't have arrhythmias, but being in a cardiac centre, we'll probably see them more commonly than in any other places. About a third of babies who have SVT are diagnosed antenatally, and the kind of main time they present is around 28 to 30 weeks gestation. It's important that you treat fetal SVT because around 40% of cases it causes heart failure and high drops in the baby. So normally mums will be given antiarrhythmic drugs like flecainide or propranolol, and the aim to be to stop the SVT. If they keep having regular episodes of SVT, then sometimes they do have to induce mum early, particularly if they can see signs that it's starting to cause high drops. So I thought it was probably worth us going over the anatomy of the heart again briefly, because I find I always forget this. So in a normal heart, you've got the SA node that starts your electrical current. It passes through the atrium and then goes through the AV node, down into the ventricles, down through the bundle of His and through the Purkinje fibres. The AV node provides this delay between the contraction of the atricles and ventricles, which obviously is important so you have time for your ventricles to fill before they contract. This action potential is achieved by opening and closing of various ion channels, particularly sodium and calcium, which move into the cells, and movement of potassium out of the cells. This is important because lots of the drugs that we use affect these channels. So the definition of SVT is a tachycardia that kind of originates and requires a kind of a structure that's above the bundle of His, so basically within the atrium, to be perpetuated. And the kind of main way you can divide them is into atrial tachycardias, which normally involve a normal ventricular rate, but you have tachycardia within the atrium, and then re-entry tachycardias, where you normally have a kind of 1-to-1 ratio of the atrial and ventricle contractions. So I'll briefly talk about atrial tachycardias. They're not that common at all, particularly in neonates. So I'm just going to touch on atrial flutter and then leave this and not kind of talk anymore about atrial tachycardias. So atrial flutter is common in older adults and occasionally can present in neonatal period as well. You get multiple sawtooth P waves, and then you will get a QRS complex, and it can kind of vary the ratio. You might have 3 P waves to 1 QRS complex, or 4 or 5. With the atrial rate runs pretty fast, between kind of 300 to 500 beats per minute, but you'd expect to have a more normal ventricle rate with that. And so as you can see in this image, you get a little kind of basically circling loop within the atrium that just keep contracting, and then every now and then that will go through the AV node and you'll have a ventricle contraction. Most of the time it's really well tolerated, tends not to cause any particular compromise, but if you do have an accessory pathway or something that allows the atrium and ventricles to contract at a 1-to-1 ratio, it normally does cause significant compromise, because if your ventricles are beating at 300 to 500 beats per minute, that obviously has quite a significant impact on you, and you're not able to fill the ventricles and effectively pump blood around the body. In neonates, so in terms of treating it, medication can be a bit variable. So it sounds like from the literature that they mostly electrically cardiovert them, but normally once you've gone into sinus rhythm, that's it. You never go back into the atrial flutter. So it's normally then well controlled once you have it, and has kind of no lifelong impact. So that's all I'm going to say about atrial tachycardias. The main type of SVT, and what we kind of talk about when we refer to SVT, is the re-entry tachycardias. So they can be divided into 2 main groups. One which is the AVRT, so atrioventricular re-entry tachycardia. So this accounts for at least 2/3 of cases of SVT in neonates. and it's mediated by having an accessory pathway between the atrium and ventricles that allows electrical activity through that pathway. So we can divide them into two types. There's something called orthodromic, which basically means that the conduction, if you see on this left image, comes from the atrium, goes through the AV node in the normal direction. It goes down through the bundle of His, but then it goes back up through the accessory pathway and then kind of re-propagates, and then you have this continuous loop in a kind of antegrade down the AV, retrograde up through the accessory pathway. So because it's still going the normal direction through the AV node and down the bundle of His, you still get a narrow QRS. P waves do exist, but they're normally completely hidden within your QRS, or you can sometimes see an inverted P wave just after the QRS complex, and it'll be inverted because it's coming from the bottom of the atrium going up rather than the usual direction that we see P waves going from the SA node down to the AV node. So this type is the most common type that we see of AVRT. The other option is you have antidromic, which basically is the opposite direction. So it goes from the atrium through the accessory pathway and then back upwards through the AV node. This looks quite different on ECG. You get a wide QRS because you're not kind of going down your normal pathway through the bundle of His and up through the Purkinje fibers. You're kind of going from another part of the heart where the accessory pathway is. That gives you a wider QRS. You normally can't see the P waves because they're hidden in a QRS, and that can look quite similar to VT. This one is much less common, and most of the babies we'll see will have the orthodromic one. Wolff-Parkinson-White syndrome basically kind of encompasses AVRT episodes when you can also see pre-excitation on a normal ECG and sinus rhythm. So that's what we call delta waves, which you can see in this ECG at the bottom. You have that kind of sloping up into your QRS complex. Particularly with babies, you might not always see this. You might occasionally get it because often, most of the time, the accessory pathway might not be being used when they're in sinus rhythm, but now and again, you'll see a little one when some of the electrical activity goes through the accessory pathway. So most patients with Wolff-Parkinson-White are able to conduct electrical activity in both directions through their accessory pathway. So you're seeing it in the sinus rhythm. When you see these delta waves, it's because it's going kind of forward through the accessory pathway from the atrium to the ventricles, and there's that little bit of pre-excitation that you see. The other main type of reentry tachycardia is the AV nodal reentry tachycardias. That's more common in older adults and children. We don't see it in neonates as much. It's a similar idea to the accessory pathways, but it's you basically within the AV node itself or just around it, you have a faster pathway and a slower pathway, and the electrical activity normally goes kind of in that same direction that we're talking about with the orthodromic AVRT, where it goes slowly through the AV node but then has a fast pathway back up again. This is also kind of looks quite similar to AVRT, the orthodromic one, on ECG, because you have narrow QRSs and you often can't see the P waves, but these patients don't have the delta waves that you can see with something like Wolff-Parkinson-White. So signs and symptoms of SVT. So lots of neonates can be completely asymptomatic. They can be sitting there looking happy and smiling while their heart rate's sitting over 200. So it can be that sometimes if they're at home, parents might not even notice that it's happening. If symptoms do occur, it can be that the baby looks a bit lethargic and pale, can be a bit sweaty, and can also not be feeding as well at the time. Older children or adults are able to obviously explain their symptoms, and they often can describe kind of palpitations or shortness of breath, feeling lightheaded. Obviously the main sign you're going to see is tachycardia, and in most episodes of SVT that might be the only kind of clinical sign you have, but if you do have, you need to kind of keep an eye out for any signs of shock. So you obviously want to monitor their blood pressure regularly, check their cap refill, that's meant to say they might have thready pulses, and obviously signs of kind of or poor perfusion to your organs, so reduced consciousness or poor urine output. So main investigations, obviously start with an ABCDE approach. You need to obviously assess the baby and check they're not cardiovascularly compromised. And then your kind of mainstay is doing a 12-lead ECG. So you want to see what type of SVT you've got, and then you want to keep the ECG running ideally as you treat it, so that you can see whether you've gone into sinus rhythm and if that's been sustained. Other investigations worth doing is worth checking their electrolytes. As we know, kind of calcium, sodium, potassium, all quite important for your cardiac electrical activity, and therefore if they're very deranged it would be worth correcting them. And also it's important these babies have echoes, so about a quarter of neonates with SVT will have associated congenital defects. Most common is Ebstein's anomaly, but also TGA and TOF can occur as well, so it's worth them having input from the cardiology team. So I'm going to ask a few questions. You can either do it in the chat or unmute microphone. So we've got this, say these two x-rays are on the same baby. The first one is before we treat it and the second one is after we treat it. Can you tell me what type of SVT we got there? So we have on the left side, so we'll start at their side, we've got a narrow QRS. You can't clearly see any P waves within it. Oh, someone's written something on it. Someone's annotating that. So you've got that. So it looks more like either an AV NRT or a orthodromic, okay, say narrow reentry. Yeah. So it's a reentry tachycardia, exactly. It could be either the orthodromic AVRT, which is the one that we said goes down the SA node and then back up through the accessory pathway. It just on that ECG alone, it could also be an AV NRT, but because we've got the one in sinus rhythm where you can see that you have these delta waves, this is Wolff-Parkinson-White with AVRT. Right. This next one, if anyone wants to make any suggestions about what you think is going, I'll say it's not VT, but it is, obviously we've got a broad QRS complex, and in this case it's actually the antidromic AVRT that we see. So it looks quite similar to a kind of VT where we've got a broad complex, and actually it can be difficult to distinguish between the two. I read the wrong one. Okay, and then last one, just to have a look at the ECG of, we've got sawtooth type atrial P waves down here. We've got about a ratio of 3 to 1. So this is atrial flutter with a normal ventricular rate. So just talk about the initial management. The first line you normally do is vagal maneuvers. So the vagus nerves supplies the parasympathetic nervous supply to the heart. It has branches that go both to the SA node and AV node. And by stimulating the vagus nerve, you slow the conduction through the AV node and basically cause a short AV node block, which then basically can allow the SVT to cardiovert back into sinus rhythm. If this doesn't work, your next step is adenosine. So that acts on the A1 receptors in the heart. That inhibits calcium channels, so basically decreases the kind of speed in which all the calcium ions can move into the cells, and therefore decreases the kind of propagation of the electrical conduction. So just to talk a bit about how we do both of these. So for the vagal maneuvers, normally there's lots of different things you can do in older people, but in neonates you would apply ice to the face. And like this baby on the right, it's like you've just dived into water, and then that stimulates the parasympathetic response. If that's not working, we go on to the adenosine. So the way we give the adenosine, it's normally, you kind of use a starting dose of about 100 to 150 micrograms per kilo. And you basically, if it's not working, you increase up in 50 micrograms per kilo increases. The half-life's only 10 seconds, so it needs to be given really quickly, ideally in a cannula in an upper limb, and you need to flush it quickly as well. You keep watching your ECG while this is happening. If you don't have a sustained sinus rhythm after this, then you can give another dose 2 minutes later. So it's good to drop all your doses, and you keep increasing until you've got sinus rhythm up to maximum of 300 micrograms per kilo. If at that point you still haven't sustained it, you need to start thinking about other options and probably talking to the cardiology team. If a patient's really shocked and not responding to these measures, and they are significantly compromised, you do need to consider cardioversion. Obviously, it's not something we do that often in neonates, luckily, but in kind of a life-threatening situation, we would need to consider that. And you use kind of 0.5 to 1 joules per kilo to cardiovert them back into sinus rhythm. So then the kind of more ongoing management to prevent it recurring, normally the first line is propranolol, which is a beta blocker. So that acts on the beta-1 adrenergic receptors in the heart, and it inhibits sympathetic stimulation of the heart. This means you kind of have a longer lasting AV node, kind of slow propagation through the AV node, and that kind of has a much long-term, more stabilizing effect than you get with something like adenosine that obviously has a very short half-life. If that isn't working, you can add in either flecainide or amiodarone or digoxin, are kind of the other options. In the baby, we had our cardiologists then went for flecainide in addition to propranolol. So that inhibits the sodium channels in the heart, and basically you reduce the electrical activity by reducing the movement of sodium into the cells. Flecainide's quite useful because it's something called a use-dependent drug, which basically means the more your heart is beating, the faster it beats, the more effective it is as a drug. So it works really well for SVT. When the heart rate's really high, it's giving more of an effect than it is when you kind of go back down into the sinus rhythm. If that's not working, then another option is amiodarone. You can't give flecainide and amiodarone together, but you can give them both in combination with propranolol. So you'd have to stop one to then start the other. That inhibits calcium and potassium channels, and through that also slows the kind of conduction rate and increases the refractory period of the AV node. Digoxin is another option. I don't think it's used that commonly in neonates, but it does increase the parasympathetic action on the AV node. And once again, they're all kind of measures to slow down the electrical activity in the heart, basically. You also need to think about anything that might be increasing the heart rate. So in older children, you might be stopping them having Coca-Cola and other caffeine, and in adults, things like stimulant drugs. But in babies, we need to think about the fact we do give lots of the preterm babies caffeine, and we need to kind of weigh up the balance as to whether what's more beneficial in terms of giving the caffeine or not giving the caffeine. And then the long-term management is normally ablation of this accessory pathway. It's not commonly done in neonates, but it might be done once you're older if you're still having kind of lots of episodes of SVT. So a bit about prognosis and potential complications. The majority of babies have complete resolution of SVT by 1 year of age. So normally they would stop the medication somewhere between 6 months to 1 year old, and then they will see whether SVT returns. So although most of them kind of grow out of it by 1 year old, up to half of those children will then get it when they're older again, normally somewhere between kind of the ages of like 6 to 10. They then might start getting SVT episodes again. If that happens, then normally they just go for definitive management, which is ablation of the accessory pathway. You can do that both for AVRT and AVNRT, and it's about, it's over like 95% successful in completely resolving the SVT. As we said earlier, SVT is normally really well tolerated by babies and most of the time has no long-term effects, but occasionally you can have some complications. So obviously side effects of the medication is quite a big one. I didn't want to go through every single medication and their side effects, but some of the more common side effects you might get with some of them are hypertension, hyperkalemia, and deranged liver function. And lots of the ones like flecainide and amiodarone do require additional monitoring of things like levels and liver function. Other side effects that you potentially could have, or other complications you can have, in babies with really prolonged SVT episodes, it can eventually lead to heart failure. It's rare, but is something being worth knowing about. There's also been reports of NEC and atrial thrombosis in babies who have quite profound SVT. So kind of wrapping up towards the end, just some advice that you might want to think about giving to parents whose baby has SVT. So you need to talk to them about the signs, what to look out for. Obviously, if we've had the baby on the unit, we know, we probably have a bit of an idea of what they look like while they have SVT, because we've seen it, you know, on the monitor, and we've seen what symptoms they may or may not have. So you can kind of talk about, you know, if the baby looks kind of pale, kind of lethargic, that it could be worth the parents checking the pulse. So we need to teach them how to check a pulse and how to count it. Obviously, they probably can't count it in SVT because it's going at over 200 per minute, but it'd be good for them to know what it feels like normally, what rate it feels like, and then what it feels like when they have SVT. In older children who get recurrent episodes of SVT, to save them, keep coming into A&E for someone to stick their head in a bucket of water and send them home again. If you've got sensible parents, they can be taught how to give vagal maneuvers to their child at home, to save them coming in and out of A&E all the time. And then it's also, again, poor feeding, lethargy, edema, that they should then seek medical attention. So in summary, it's one of the more common arrhythmias in neonates. Most of them are AVRTs, which are mediated by an accessory pathway. Your main kind of emergency management is for vagal maneuvers and adenosine. Most babies grow out of it by age 1 of life, but for the ones that come back, often they end up needing ablation. That's it. Does anyone have any questions?